Hello everyone. In this lecture we're going to be talking about the urinary system. In this lecture we will cover the gross anatomy of the urinary system, the formation of urine, the control of urine volume, elimination of urine, urinalysis, and renal and urinary disorders. Prior to 300 BC, physicians were diagnosing patients based on observations, palpations, and auscultation. So by looking at them, touching them, a physical examination, and by listening, they were diagnosing patients and suggesting treatments. Then around 400 AD, Hippocrates started advocating for the examination of urine. And some things that he was doing was looking at the color of the urine, seeing if there was sediment in there, smelling it to determine if it had an odor, and actually tasting the urine on some occasions to see what was going on with the patient. He also attributed bubbles in the urine to kidney disease. And by 900 AD, the examination of urine had become a mandatory practice. And if a physician did not examine the urine, then they were in violation of Code 1090. And that violation meant that the physician was subjected to public beatings. And in 1300 AD, uroscopies had become a common practice. And in 1500, urine color charts were developed for a diagnostic tool. And, if you fast forward to today, you know that their medicine continues to advance every day. And so I look forward to talking to you about what has happened between 1500 AD and today. The kidneys play an integral role in the maintenance of homeostasis. They help to clean the blood of waste products. They also help to maintain electrolyte balance, water balance, and acid-base balances in the body. So where are the kidneys located? Well, they're located under the back muscles and just behind the parietal peritoneum. So we talked about the parietal peritoneum lines the abdominal cavity, and if we were to enter the abdominal cavity and go all the way to the most posterior area of the abdominal cavity, we would find that back lining the peritoneum, and if we were to go behind that, that's called the retroperitoneal space, and that is where the kidneys live. The right kidney is a little bit lower than the left one, and that's because we have Mr. Liver taking up this huge area in our right upper quadrant. So the right kidney is kind of pushed a little bit lower because of that. Some of the structures that we're going to look at is the different structures of the kidney, and then we'll look at the ureters and the bladder. So I have a couple images coming up, so stay tuned for that. This image gives us a good look at the external anatomy of the urinary system, and then we will dive a little bit deeper and look at the internal workings of the kidney. So for now, this image over on the right, this is actually a feline urinary system, but you'll see that it looks a lot the same. And so if we go back to the image on the left, you can see our kidneys here. We got our adrenal glands on top of the kidneys, and this is the left of the patient or the individual. This would be the right of the individual, and you can see how this right kidney sits a little bit lower. Like I said, that's because the liver is taking up a whole lot of space, and so it's kind of shifted down because of that. Now, a couple important external things to look at is you can see that the kidney is kind of shaped like a lima bean, and where that little indentation is, right here, I'm circling on the right kidney, this is called the hilum. And the hilum is where the vessels enter, and the nerves and the ureters as well, right around that area. So, you know, when we are discussing the hilum, it has all of those important structures in there. So coming down from each kidney, we have the ureter. It's this long tube that carries urine that is made in the kidneys, in the functional units of the kidneys called the nephrons. And then urine will drain into the calyces, which we will look at more closely on the next slide. And it flows down through the ureters via peristalsis and then into the holding tank, which is Mr. Bladder. All right, and we have two kidneys doing that, right? So, and then from the bladder, we have the urethra that extends posteriorly, distally, I guess, and that actually transports urine to the outside. Okay, so here's that inner look at the kidney, this cross section here, or this coronal cut, if so we could just kind of open the kidney like a book and look in the middle and see what's going on there. And so some structures that we need to draw our attention to first is the renal cortex. That's this outside area here is the cortex. When I hear the word cortex, my mind immediately jumps to core, but not necessarily the translation of the word cortex. Cortex comes from the Latin word for bark. So the cortex of the kidney is the outer layer of the kidney, this kind of whitish area that you see here. And then the inner portion of the kidney is called the medulla, or the medulla, and that is here. So the medulla is this inner portion here. And within that inner portion, we have something called renal pyramids. And so if you see each of these little triangular shaped doodads right here, there's a whole bunch of them. Those are called the renal pyramids. And the extensions of cortex or cortical tissue that extends down between them, those are called the columns, the renal columns. So we'll come back and we'll talk a little bit more about those pyramids because that's where the functional units of the kidneys live. So we'll circle back, stay tuned for that. And then the renal papilla are the narrow innermost ends of the pyramid. So let me just circle the papilla. That's one. Papillae would be more than one, and you can see each of these have a papillae, and as urine is made, urine is going to drain out of these papillae and into these calyces. And the calyces is the division of the renal pelvis where that receives that urine, and then urine is going to drain out here, and this is the ureter that we're looking at here. This is Mr. Ureter. So then urine's going to drain out the ureter into the bladder, and then eventually, hello, outside world. Again, just as a review, the words to go with the image that we just looked at, those renal pyramids or those triangular shaped areas of the kidney where the functional units live, and we're going to look at that next. And each of those taper down to kind of almost a point, like on a triangle, and that's called the renal papilla, remember? And the renal papilla, each of those kind of snuggle up against one of those branches of the calyces, or a calyx is one. And that's where urine is going to drain down into that papilla, enter that calyx, and be collected in the calyces and eventually make its way down the ureter. Okay, So now we're going to zoom in a little bit closer and we're going to look at the functional units of the kidney. So this is a microscopic view that you see here of the nephron. And we have more than 1 million of these nephrons in each of our kidneys. So we have a lot of them that are helping to clean that blood, take out the waste, regulate fluid, all of that awesome stuff. This is where all the magic happens. So if you take a look at this nephron, we can break it up into two principal components, the renal corpuscle and the renal tubule. And then the renal corpuscle can be broken down into 2 more parts, and the renal tubule can be broken down into 4 more parts or segments. So in the next couple slides, we're going to be looking at this basic anatomy of the nephron. So couple things to point out on this slide. One, that this section right here is the cortex. And that cortex, I'm going to put a purple line, is right here. Okay, the cortex is that outer bark-like part of the kidney. So there's the cortex, and you can see we have tons and tons and tons of the renal corpuscles and parts of the convoluted tubules that are actually up in the cortex. And then we get into that the renal pyramid. I'm going to make it blue. This renal pyramid is this part. It's in the medullary, or the inner portion of the kidney, and so let me draw a line. All right, so see there, so this is the medullary part. That's where those renal pyramids are, and then they taper down to the renal papilla, and you can see that kind of makes sense because we have all of these distal ends of the tubules. There's going to be a bazillion nephrons, okay, only 1 million, but they're all going to be up here and they're going to do their job, and then they're all going to drain their waste products into this one collecting duct, and then that's going to filter into the calyces. Remember, the calyx is going to be down here coming off like this. Okay, so this is kind of the overview of the nephron, and we're going to dive in a little bit deeper and look at the corpuscle and the renal tubule. Okay, so now we're going to talk a little bit more in detail about the renal corpuscle, and there's 2 parts that we're going to talk about: the glomerular capsule, or also referred to as Bowman's capsule, and then the glomerulus. Glomerulus is one, glomeruli is plural. Okay, so the Bowman's capsule is part of that renal tubule. It's an extension of the renal tubule, and it kind of comes around and it gives the glomerulus a hug. And the job of the glomerular capsule is going to be to absorb that waste fluid. And the second functional component of the renal corpuscle is the glomerulus. And the glomerulus is a network of capillaries, and like I said, it's getting a nice hug from that Bowman's capsule. So the afferent arteriole is going to be bringing blood into the glomerulus, and the efferent arteriole is going to be sending blood out of the glomerulus. Okay, so it's going to enter the glomerulus, and there's going to be exchange. There's going to be a filtration of wastes from the capillaries out into the renal tubule. And there also could be some reabsorption occurring simultaneously, diffusing out through the walls of the tubule. And we'll talk in more detail about the tubule coming up here on the next slide. An important thing to note about these renal corpuscles, the majority of them are located in that cortex, like we talked about before, about 80% of them. The other 15% are located a little bit lower where the cortex and the medulla meet. So we call those juxtamedullary nephrons, and they have an important role in concentrating urine. And like I said, they live in that little in-between area where the medulla and the cortex meet. Now we're going to take a closer look at the renal tubule, and where we were on the last slide, let me just highlight that for you. We talked about, here in blue, the glomerulus and Bowman's capsule, or the glomerular capsule. And that, we talked about the Bowman's capsule is kind of the beginning of that renal tubule. It's right here. Okay, so there are 4 parts to the renal tubule. The first part is the proximal convoluted tube. And the reason we call it convoluted is because it has many twists and turns. So this conglomeration of twists and turns and loops, that serves a purpose, and we'll talk about that in more detail later. But it's kind of similar to the small intestine. Remember, we said the small intestine's job is to absorb nutrients. So this is kind of the same situation going on here. We have this very long twisty turny tube that really increases the contact time that waste that's been filtered out of the blood is flowing through this very convoluted tube, and that allows for reabsorption of a majority of the components that were filtered out of the blood. So this very long pathway has a purpose, and it's pretty ingenious. So this very first convoluted portion off from the capsule is called the proximal tube, and it's nearest to that glomerular capsule like we talked about. From there, we take this very long looping route, all right, this hairpin turn. This is called the loop of Henle, or the nephron loop. And the loop of Henle extends into that renal medulla. This part that comes directly off of the proximal tubule is called the descending, because it's going down, remember, same with descending colon, and then it makes this hairpin turn and it climbs back up the mountain, and that's the ascending portion of the tubule, alrighty? And it is not convoluted, right? It just has that one little turn. And next up, we come to the distal tubule, and it is again convoluted, and it is an extension of that ascending limb of the loop of Henle, or the nephron loop. And then the last little portion is the collecting duct. And the collecting duct is not convoluted, it is straight as well, and we have many distal tubules from other nearby nephrons that join up into this one collecting duct. And this collecting duct extends down into the papilla, and there it is collected in the calyx. It is moved into the renal pelvis. It exits via the ureter into the bladder, and then eventually out through the urethra to the world. Here's another peek at where these functional units are located. Remember, the 85% of them are located up here in the cortex, and you can see how there's others that are a little bit lower. Those are the ones that are located by the junction of the cortex and the medulla. We call those the juxtamedullary nephrons, and you can see the convoluted tubules, and then eventually how they drain into this one collecting duct here. Like the liver, the kidney performs many essential functions for us. So just a shout out to the kidneys. Thank you for all you do for us and all the hard work to keep our bodies in homeostasis. So some of the things that the kidney does, well, it excretes wastes, right? It maintains homeostasis. It also regulates water balance. So does our body need us to hold on to water, or does our body need us to get rid of water? The kidney knows that. It also regulates salt in the body. So if it holds on to salt, our body's going to hold on to water. If it lets salt go, our body is going to let water go as well. Remember, water follows salt. It also helps in the regulation of pH, and it produces a hormone called erythropoietin. Remember the word hematopoiesis? Remember, hematopoiesis is the production of red blood cells, and so erythropoietin, or EPO, is going to signal the red bone marrow to make red blood cells if there is a determination that the individual is hypoxic or the body doesn't have a sufficient supply of oxygen. Then the kidneys are going to release EPO. That's going to signal the red bone marrow, and the red bone marrow is going to go to work making more red blood cells so they can carry more oxygen to the rest of the tissues in our body. It's amazing. Okay, what else do? They filter blood. We talked about that. So they filter, they excrete, and they're going to reabsorb. So the majority of products that get filtered out by the Bowman's capsule are going to get reabsorbed during their journey through the tubule. All right, so filtration. And then lastly, secretion, all right, is going to be performed by the kidneys as well. So they have a big job to do. Again, thank you, kidney. Like we discussed previously, the role of the kidney is to maintain homeostasis of our body, and it does that in 3 major ways. Now this slide lists out 4. It kind of breaks reabsorption into 2 specific areas, but the 3 broad overarching processes are filtration, reabsorption, and secretion. So glomerular filtration, water and solids move from the blood into the nephron, or that glomerular capsule. Remember, the glomerulus and the glomerular capsule work together as that filtration unit. Then reabsorption is going to occur in the renal tubules, and useful substances are going to move from the filtrate into the blood, and wastes and excess substances that the body doesn't need are going to be excreted. So we're going to talk about each of those in a little bit more detail. Filtration of urine begins at the renal corpuscle and is the beginning of urine formation. So what is happening is we have blood coming into the glomeruli, or glomerulus for one, and the pressure there is really high, and that pressure is going to push water and other dissolved substances through the membranes and into the glomerular capsule. This is where filtration begins. That filtration rate is approximately 125 milliliters per minute or 50 gallons each day. And this results in overfiltration because we all know that we don't urinate 50 gallons a day, right? So there's an overfiltration process happening here. And as this waste or filtrate travels along the renal tubule, a majority of that water and dissolved substances is going to get reabsorbed into the bloodstream. So now we're going to talk about reabsorption, and I think this could easily be the most complicated concept in this chapter, so I've tried to create this flow chart that hopefully has kind of simplified and broken down the steps. So after filtration has occurred between the glomerulus and the Bowman's capsule, now we have a substance called filtrate. And this is where reabsorption is going to begin, is in this first part of the renal tubule called the proximal convoluted tubule, or the PCT. So reabsorption begins when the filtrate moves from the capsule into the PCT. And so what is happening here in the proximal convoluted tubule? Well, a lot of stuff is moving out of that proximal tubule, and some of the stuff that's moving out is directly because sodium is being pumped out of the tubule. So sodium is going to move out. Remember, this initially takes place predominantly in the cortex, which is what we refer to as hypoosmotic. What this means is that the kidney tissue has varying concentrations of salt. And so in the cortex, that area is not very salty. So we call that hypoosmotic. And this really dictates how reabsorption occurs. So in this proximal convoluted tubule, we have sodium moving out of the tubule, and as sodium moves out into the interstitial fluids and into those peritubular capillaries, chlorine wants to follow. So chlorine is going to follow, and when that happens, that is going to cause water to follow out as well. Now, glucose and vitamins also leave the tubule at this point as well. And so we move from the proximal convoluted tubule into the loop of Henle, and that first downward portion of the loop of Henle is called the descending loop of Henle. And this loop, part of the loop, is going to dip way down into the medulla, which is increasingly salty or hyperosmotic. And this is going to encourage even more water to leave the tubules. Remember, we said that we reabsorb about 2/3 of the water that's filtered out into the filtrate, and this is what causes that to happen. This extremely salty environment of the medulla is going to cause more water to move out because water follows salt. So more water is going to be encouraged to leave this descending loop of Henle. Okay, so now we make the turn and we're coming back up. The book refers to this as a countercurrent mechanism. And so now we have the ascending loop and we're moving back up towards the cortex, and water is now not going to be able to move across this membrane. It's going to be impervious to water because we don't want to take back in all of that water that we just, diffused out through osmosis. So there's going to kind of be a lockdown on that ascending tube, and it's not going to let water back in or out across that membrane. But sodium's going to be continuously pumped out through active transport. And what this is going to do is it's going to change the chemical charge of the blood, and this is going to encourage the diffusion of more of those negatively charged particles and water to move into the blood, right? Because we've moved sodium out of the tubule and into the interstitial fluid, and now it's going to get pumped across, actively transported into the peritubular capillaries. This is going to cause chlorine to follow, and when that happens, water is going to move into the capillaries here. Okay, so everything is kind of like following sodium. Sodium is the leader of the band, and everybody is going to kind of take sodium's lead. Now, the remaining filtrate in that distal tubule is going to move into the collecting ducts for excretion. And then remember, the collecting ducts, they terminate in that renal papilla, which then drains the urine into the calyces of the renal pelvis. And then that urine is going to flow down the ureter and be collected in the bladder and eventually be secreted or excreted, by the body. Before we leave the topic of absorption, there's two other components that we need to talk about, and that is transport maximum and renal threshold. And basically what this boils down to is there are specific transport molecules that move certain components out of the tubules and into the blood capillaries. So let's say we're talking about glucose. There are so many transport molecules or transporters, let's say, that can move glucose across the membrane. And once all of those transporters have been exhausted, this is called the renal threshold. So that's the transport maximum of any substance. That's going to give us a specific number of what the amount of substances in the blood that can be transported. And then once we reach that renal threshold, the rest of that component will be excreted in the urine. As I mentioned previously, glucose is reabsorbed in the proximal tubule and back into the blood to be used for energy. So that's that first segment of the renal tubule. If there is too much glucose, aka there are not enough transporters available to transport the number of glucose molecules that we have, we're going to reach that renal threshold, and as a result, the rest of that glucose is going to remain in the tubules and it's going to be excreted in the urine. Now, this is a sign of diabetes and it's called glycosuria. Now, this can also lead to less water leaving the tubules by osmosis. So then we're going to have excessive urination, right? Because not enough water is leaving the tubules and going into the blood. More water is going to be held in the tubules and excreted as urine. And this is referred to as polyuria. And then lastly, this is a domino effect. That means if we are excreting too much water and we're not holding on to enough of it, then the body's going to say, hey, you need to drink more water. And so that individual is going to be really thirsty, and that is called polydipsia. So we've talked about filtration, we've talked about reabsorption. The last part of this amazing process is secretion. So secretion is movement of substances into the urine, right? Or retained into the filtrate or moved into the tubules so that it can be excreted by the body. And this could be in any number of things. It could be hydrogen ions, because the kidneys are responsible for helping maintain that pH balance. So if the blood is too acidic because there's too many hydrogen ions, then those are going to be picked up or moved into the tubules for excretion. It could also be various other ions like potassium, urea, which is a waste product, uric acid is a waste product, creatinine, and other certain drugs. If you are, an avid vitamin taker, then any amount of vitamin that is over that renal threshold is going to be excreted in the urine as well, and some in the feces too, I would suppose. And then ammonia would also be secreted as well. Okay, so what other processes help us control the volume of urine? I'm glad you asked. There are 3 of them that we're going to talk about. We're going to talk about antidiuretic hormone, atrial natriuretic hormone, which is ANH, it's at the bottom of the slide there, and aldosterone. Okay, so the first one, ADH, is secreted, if you remember, by the posterior pituitary gland, and this is going to decrease the amount of urine. So more is going to be staying in the system and reabsorbed into the bloodstream, because this makes those collecting ducts that I told you were locked out water, right? It's going to make them permeable to water. All right, so when we're coming around the loop of Henle and we're heading towards that collecting duct where water is not supposed to be moving in and out, now antidiuretic hormone is going to allow more water to still leave the tubules and go into the bloodstream. That's going to make us have less urine, it's going to increase blood volume, it's going to help us hold on to water. Okay, that's that one. Now what about aldosterone? Aldosterone is secreted by the adrenal gland, and it's triggered by something called the RAAS process. Okay, and this process is going to, oh, by the way, RAAS stands for renin angiotensin aldosterone system. All right, it's like the emergency broadcast system for the kidneys. Okay, so what this is going to tell the kidneys to do is it's going to tell the tubules to allow for reabsorption of sodium into the bloodstream at a faster, higher rate. And remember, if sodium is leaving the tubules and going into the capillaries, water is going to follow. So what do you think is going to happen to blood volume? Blood volume is going to increase, right? And what's going to happen to urine? Urine is going to decrease. So again, aldosterone is telling the body to hold on to more water. Okay? Now, the last one, our atrial natriuretic hormone, is the opposite of those 2 guys. Okay, it's different from all of the rest, and the reason is because it is going to have an opposite effect on the body. All right, so we refer to this hormone, ANH, as the salt and water losing hormone, right? Aldosterone is a salt and water retaining hormone. ANH is going to be a salt and water losing hormone, right? So losing means it's not going to go into the bloodstream, right? There's not going to be as much sodium leaving the tubule and going into the capillary. Instead, there's going to be a lower amount of sodium leaving the tubules. Therefore, not as much water is going to leave the tubules. Okay, and what's going to happen when we have more water staying in the tubules? urine is going to increase and our blood volume is going to decrease. Now, it's significant that the ANH hormone is secreted from the atrial wall of the heart. What better place to sense what the fluid volume is or blood volume than in the atria of the heart? Okay, so this is that controlling mechanism that is going to, if the sensors in the atria are sensing that the blood volume is too much, then this hormone is going to be secreted so that more urine is excreted. Okay, I hope this makes sense. So there are three different terms that are associated with abnormal amounts of urine, and the first one is anuria. Anuria is the absence of urine. And then the second one we need to know is oliguria, which means scanty, which is one of my favorite words. Say it with me, scanty amounts of urine. Then we have our normal urine output, ta-da. And then the very last term we need to be familiar with is polyuria, which is an unusually large amount of urine. So urine volume or output is significant when we're trying to determine, is there some type of pathology going on within the patient? Is there a disease or a condition or what have you? So monitoring what an individual takes in, their input, and what they excrete, their output, is very important. And we call this I and O. I and O, the ins and outs. All right, so let's set the stage for where the ureters come into play. The blood has been filtered by the renal corpuscle. It has traveled the length of the renal tubule. It has now passed into the calyces in the renal pelvis, and ta-da, here we are at the ureters, and you can see them here highlighted in yellow, and you can also see what they look like from a cross section. They have this transitional epithelium that lines them and the bladder, right? Remember, transitional epithelium allows a lot of stretchiness, right? So they're very stretchy, and they also have smooth muscle, and they move similarly to how the bowel does by peristalsis. So urine is going to travel via peristalsis down the ureters. Now, how long and how wide are these ureters that we speak of? Well, they're about 1/4 inch wide and about 1 foot long, 10 to 12 inches long. Okay, now they're richly supplied with sensory nerve endings, and this makes for a bad situation if we have a stone that is trying to make its way from Mr. Kidney through the ureters down to the bladder. So this can be extremely painful, and it can cause episodes of something called renal colic. And renal colic, it gets its name from this cramping thing that the colon does, right? So it causes this extremely painful cramping sensation. You know, there could be flank pain, there could be some different situations, symptoms associated with that we'll talk about in a little bit. However, here are the ureters in all their glory. Once urine has traveled down the length of the ureters, it arrives in the bladder. And the bladder is the holding tank or the reservoir for urine, okay, until it gets excreted. Now, in the female individual, the bladder sits in front of the uterus, and this can cause a problem if she's pregnant and the baby's growing. It can feel like baby is sitting on the bladder. And then in men, the bladder rests upon the prostate. And you can see the bigger image of the bladder. That is indeed a male. You can see that the prostate gland is right at the base of that bladder. And then there's a side view of both male and female. And you can see how that uterus kind of flops right over the bladder. And that can definitely be a problem as baby is growing in the womb. All right, so like the stomach, the bladder has those little folds called rugae, right? And we can see those when it's empty, but when it's filled, it may look very stretched and smooth. Now there's one area where it's always stretched and smooth, and let me sketch it out for you. So right here, if you can see where I'm circling in red, that is the opening of one ureter where it dumps its contents into the bladder. And then here's the other side, these two little openings. And right down here, this is where the urethra starts. Okay, so if we were to connect these, we would get this triangle shaped area of the bladder, and this is called the trigone. All right, the trigone, if we were to just connect those three structures like I showed you there, then that would be what we call that area right there. It is free of rugae. It's on the posterior wall of the bladder, and it's very smooth, and the reason it's smooth is because it's tightly fixed to the deeper muscles within the bladder. And when we're in surgery, sometimes we do bladder biopsies, and so the surgeon's going to say, okay, this came from this spot of the bladder, and this came from that spot of the bladder, this came from the trigone. And it's really important that we label those accordingly, especially if we're looking for something like bladder cancer. Here we are finally at the moment of truth where urine gets to exit the body, and that is via the urethra. The tissue of the urethra is continuous with that inside lining of the bladder, and this is important because that can actually increase the chance of infection spreading upward from the urethra into the bladder. It can just track right up through there, and that can result in cystitis or inflammation of the bladder due to some sort of invading microorganism. The urethra is this narrow little tube, and for females it's about 4 centimeters or 1.5 inches long, and in males about 20 centimeters or 8 inches long. And in the male, the urethra has 2 purposes. And the first purpose is, of course, to serve as a passageway for urine to exit the body or be excreted. And then the other is a passageway for the movement of reproductive fluids from the body as well. And because females have this much shorter urethra, they are more prone to infections such as cystitis, because there's a very short pathway for microorganisms to travel from the outside of the body up the urethra and then into the bladder. Excreting urine from the body is known by several different names. One of them is micturition. Another is urination. We could also refer to it as voiding, okay? And there are 2 sphincters or 2 muscles that control the release of urine or the passage of urine from the body, and there's an internal one that we do not control. It is involuntary. It's right inside the bladder. And then there is an external urethra that is that we have the ability to control, and that circles the urethra just below the neck of the bladder. So internal one is located at the bladder exit. External one is located just below the neck of the bladder. And this bladder wall permits the storage of urine with little increase in pressure. And then as the bladder gets more full and more full, so we probably won't notice anything until the bladder gets to a certain fullness, and then we will have that feeling that we need to urinate. And that emptying reflex, quote unquote, is initiated by nerve impulses that come from various sacral segments of the spinal cord, and that causes our bladder wall to contract. That bladder, the muscle that contracts the bladder is called the detrusor muscle, and our lower pelvic abdominal muscles also help to excrete urine as well. Now, if that emptying reflex doesn't work like it's supposed to, then we have some other situations that can occur. One of them is enuresis. And enuresis is that involuntary urination in young children, and that could be just because they haven't developed that ability to voluntarily control the passage of urine. So that maybe there's some sort of maturational delay there. Something else can be urinary retention. Urinary retention is when urine is produced, but it can't leave the bladder. All right, so it's in the bladder, and for whatever reason that it is unable to be emptied. That's typically caused by some sort of obstruction. A common one in males is enlarged prostate. The part of the urethra of the male does pass right through the prostate. That's called the prostatic urethra. And if there's an enlarged prostate, that can start pressing back on that passageway and can actually pinch it off. Other things that could become lodged further up the system in the ureter could be a kidney stone. Other various situations could be some sort of nerve damage. Medications can also, some medications can cause that, as well as a stricture or a narrowing down in the ureter or the urethra to that will not allow urine to pass. The other is urinary suppression. So urinary suppression is the kidneys are not producing any urine, but if they were, the bladder would remain functional and be able to empty itself. So it's not a problem with the bladder, it's a problem with there isn't any urine, right? It's anuria. That could be caused by several different situations. It could be that there is some sort of progressive disease with the kidneys. It could be caused by trauma as well as spinal cord injuries that innervate the kidneys. It would be characterized by a volume of urination that's less than 100 mLs per day. There are some terms associated with urinary incontinence that we need to be aware of, and the first one is stress incontinence. And incontinence just means that we're unable to control the passage of urine. And so some urine is escaping when we don't want it to. And so stress incontinence is often used to describe the type of urine loss associated with some sort of strain, and then there's uncontrolled urination. So that could be laughing, coughing, lifting something heavy. That is all associated with stress incontinence. And then the next one in the list would be urge incontinence, and that we often refer to as overactive bladder, and that is associated with the overactivity of the bladder wall. All right, so there's a frequent feeling of needing to urinate. And then overflow incontinence is characterized by intermittent dribbling of urine. So this can result from urinary retention or an over-distended bladder, a bladder that's too full. It's too full, you can't hold it anymore. Okay. Sometimes this becomes the situation when we have a male with an enlarged prostate, and we'll talk about that more in another chapter. The book also goes over reflex incontinence, which could be due to some sort of nervous system disorder, and we refer to that as neurogenic bladder. So here we see in this image a few individuals that are lined up with their urinalysis and they're getting ready to sample it. Yeah, no, I'm just kidding. But remember, way back when, Hippocrates did advocate for the tasting of urine. You smell it, you taste it, you look at the color, you see if some bugs like it. Not today. Not today, folks. Today we do it a little bit differently with something called a routine and microscopic urinalysis, or simply R&M. All right, so we do still look at color. We look at the turbidity. Is it cloudy? Does it have sediment? Does it have an odor? But we're not tasting it. All right, we're not doing that. Various types of analyses will give us clues into what is going on with our patient. Various different abnormalities in color could mean that there's some sort of infection, maybe there's blood cells in there, those kinds of things. It could also be due to diet. An odor could also be due to what we eat, right? If we eat different types of foods like asparagus, have you ever noticed that, you eat asparagus and then when you have to urinate, it does smell like asparagus, which is interesting. If it has a strong or sweet or fruity smell, that could indicate acetone. That could tell us that the patient has uncontrolled diabetes. If it has a musty odor, that could mean PKU or phenylketonuria. Various other tests like what is the pH like? If the pH is high, that could indicate alkalosis, or if it's low, that could indicate acidosis. And then there's something else called specific gravity, and if we have a specific gravity that's above normal limits, that could indicate glycosuria, proteinuria, dehydration, perhaps kidney stones is the case. And then if it's below normal limits, that could indicate chronic renal disease as well, and or overhydration. Yes, we can suffer the consequences from overhydrating ourselves by drinking too much water. Could actually cause death. All right, that's urinalysis. Over and out. All right, now we're going to move on and talk about some different types of disorders of the kidney and the urinary tract. And the first one on our list is obstructive disorders. And these disorders interfere with the flow of urine. Now, if urine cannot flow then it's going to back up into the kidney, and that's going to cause that renal pelvis where the urine collects to become enlarged, and we refer to that as hydronephrosis. One of the reasons there could be a blockage could be because the stone is stuck there. The kidneys make the stones, there's some crystallized material in there, and a part of it can break off and go roaming about through the urinary system, and it could get to a spot where it can't move. It's going to cause a blockage and that renal colic that we talked about before. And then tumors could also be a situation, right? Renal cell carcinoma or kidney cancer and or bladder cancer, which is often characterized by hematuria. Here we're looking at an image of a hydronephrosed kidney, so you can see how dilated this renal pelvis is here, and where the calyces are, that those are extremely enlarged. Again, if urine can't flow, it's going to back up into the kidney, and that's what's going to cause this hydronephrosis. Here we're looking at some lovely rock candy. No, just kidding. These are renal calculi, right? These are kidney stones. The kidney stones are formed in the kidney and then they get washed downstream, right? And sometimes they can block the flow of urine like we talked about. So I bet you're curious to know what the biggest size stone was that was ever removed from a human. I happen to be able to tell you that. A man in Kensington, England, had the biggest recorded stone removed from his kidney, and it was 20 centimeters across. Another individual, male in Canada, passed 5,704 stones. That's the most stones ever documented that one human passed. Okay, so if we have a situation where there's a stone that is stuck in the ureter, we're going to bring that individual into surgery, and we can break it up with a laser and into smaller pieces that will allow it to flow downstream and get washed out. If individual has a lot of stones in the kidney, we can do something called an ESWAL procedure, and that stands for extra corporal shockwave lithotripsy, ESWA, and that is actually, it's a non-invasive procedure, but we do bring them into the operating room and put them under general anesthesia because it's very painful, and then those shock waves are actually delivered outside of the body, but through the abdominal wall of the body and penetrate the kidney to help break up those stones. So there they are, lovely kidney stones. Here is an image of what a cystoscopy might look like. We also perform these in the operating room where they'll put a scope through the urethra and up into the bladder. We'll also instill some water or glycine, they use a lot of times, in the bladder to kind of distend it so we can get a peek around in there. What's significant for us in the role of the surg tech is if they are doing bladder biopsies. They may take 20 different biopsies, and it's going to be our responsibility to make sure that they're labeled correctly, right? Because if we're trying to diagnose cancer and we mislabel a specimen, that could result in a diagnosis of cancer in the wrong part of the bladder. So that is the biggest role that we play in these cystoscopies if they're going to be taking specimens. That brings us to UTI, or urinary tract infection, which is the most common hospital-acquired infection out there. typically caused by different types of gram-negative bacteria, can lead to urethritis, which is inflammation of the urethra. That bacteria can track up into the bladder to cause inflammation of the bladder or cystitis. It can also continue to move upstream into the kidney, and then we get pyelonephritis, right? And that last word there, nosocomial, that is the same as hospital-acquired infection, and a lot of those occur due to catheterization in, during surgery or right before surgery or whatever. So if we can avoid catheterizing our patient, that's probably the best plan of action. Glomerular disorders have to do with the glomerulus and it's malfunctioning, or it's not doing what it's supposed to do, and that can lead to something called nephrotic syndrome. And nephrotic syndrome is a collection of signs and symptoms that accompany various glomerular disorders, and it's characterized by a few different things. One is protein in the urine, or proteinuria, hypoalbuminemia. Remember, albumin is going to increase blood volume, right? So if we're losing albumin, then there's going to be also an effect with our blood pressure as well. So with this situation, fluid is allowed to leak out of the blood vessel. That's going to reduce blood volume, and it's going to go into the tissue spaces. If it's leaking out of the blood, it's going to go into the interstitial space, and that's going to cause edema, systemic edema. Two other types of glomerular disorders are acute glomerulonephritis and chronic glomerulonephritis. Acute glomerulonephritis is typically caused by a delayed immune reaction to a streptococcal infection, similar to when we talked about rheumatic heart disease and how that can be caused by rheumatic fever, and it damages the valve, the heart valve. So we have a similar thing going on here, but it's attacking the glomeruli. And when that happens, it's typically a very quick onset. We treat with antibiotics, and typically the patient recovers. However, it can cause some permanent damage to the glomeruli, which can then down the road lead to chronic glomerulonephritis. And this, of course, chronic means that it's continues to progress over a long amount of time, and chronic glomerulonephritis can lead to renal failure, and in the early stages can be relatively asymptomatic, and then as it progresses, we kind of get the same symptoms we would see with acute glomerulonephritis, which are hematuria, proteinuria, oliguria, and edema. And then it is also believed that some immune mechanisms can be the major cause of chronic glomerulonephritis, like hypersensitivity, as we've talked about in previous lectures. A blood urea nitrogen test is a test that we can use to assess if a patient is in acute renal failure. Urea is a waste product that is filtered out by the kidneys, and so a BUN test is going to assess those levels of waste in the blood, and if they're not being filtered out, that could clue us into that there's something going on with the kidney. Kidney failure is also referred to as renal failure, and it is basically means the kidneys aren't able to do their job, so they're failing, right? There's two different types. The book talks about acute and chronic. Acute renal failure is an abrupt reduction in kidney function, and it can be characterized by oliguria, a rise in nitrogenous waste in the blood, And so there are various factors that can cause acute renal failure. It could be associated with blood pressure or hemorrhage, severe burns, acute glomerulonephritis or pyelonephritis, or an obstruction of the lower urinary tract that is causing extreme stress on the kidney. But typically, if we get that diagnosed and treated, then recovery is typically rapid and complete. Chronic renal failure, on the other hand, is a slow progressive condition, and that results in a gradual loss of the functional units of the kidney called the nephron. And there are different diseases that can cause that as well, including diabetes, various infections, also glomerulonephritis, tumors, systemic autoimmune diseases, and obstructive disorders are included in there as well. And in that list, associated with chronic renal failure is something called polycystic kidney disease, or PKD. And what happens with PKD is the kidney tubules are lined with these epithelial cells, and they start to grow out of control, and they make these little pockets, and urine backs up into those pockets. And so you have this kidney that looks like it has these big lumps all over it, and that is characteristic of PKD. It is hereditary. It's not too common. It appears in 1 in 5 to 1,000 persons, and the symptoms that we get with that are like flank pain, blood in the urine, and then that can lead to chronic renal failure. Here are a couple polycystic kidneys for your viewing pleasure. This top left, you can see all these chambers, these cysts that have developed, and those fill with urine. And this other image down here, you can see this is this big blue basin. This is a gigantic polycystic kidney filled with all of these, covered with all of these little lumps that are the cysts, the urine-filled cysts. All right, we're coming into the home stretch here. We're just going to discuss the 3 different stages of kidney failure. And the first stage, stage 1, there is going to be a loss of some nephrons, but the patient is going to be asymptomatic. So they probably won't even know that they have anything kind of going on in their kidneys. Stage 2, now we're going to start to have some symptoms. Stage 2 is also referred to as renal insufficiency, and now we're going to have some loss of function. And because of that, we're going to see blood urea nitrogen rise, and we're also going to see polyuria as well as dehydration in an individual with stage 2 renal failure. And then as it progresses to stage 3, this is a life-threatening situation where if the individual does not get a kidney replacement or some sort of other assistance, then they will not survive. All right, here we are. We made it. Give yourself a hand. That was a lot of listening. I know it was a lot of talking. I hope that it helped to make some of the more complicated concepts associated with the urinary system make a little bit more sense. And I look forward to discussing this chapter with you in our next class.